So the first thing we will learn, we'll start with ovulation. So what is ovulation? Ovulation is the key for conception. It is a release of egg from ovary. So if at all we have a female of regular ovarian cycle, regular menstrual cycle, the ovulation occurs between 12 to 16 days. All right. Now, the menstrual cycle in a regular follicle, regular cycle female, it is divided into 4 parts. The early follicular phase, which is between day 5 to day 7. The late follicular phase, which is between day 11 to day 13. The early luteal, mid luteal or early luteal it is called as, it is between the day 15 to day 17, that is post ovulation. And the late luteal phase, which is between day 26 to day 28. Mind it, here we are talking about a female who has regular cycles of 28 days only. Alright, so now we will discuss a little bit of detailed physiology for ovulation and how different hormones work at different phases of menstruation. For that, first we have to discuss about the HPO axis. Now, what is HPO axis? HPO axis is hypothalamo-pituitary ovarian axis. So, hypothalamus releases gonadotropin releasing hormone, right? And it stimulates the anterior pituitary, which in turn releases gonadotropins. So, what are gonadotropins? Gonadotropins are FSH and LH. As of now, we will be talking about follicle stimulating hormone. This FSH, it stimulates the gonads and also it recruits the follicle. It stimulates the follicle and the gonads then release sex hormones, which are estrogen and progesterone. So for recruitment of follicles, we need estrogen. Now this estrogen increases as the cycle progresses and it is at peak at the time of ovulation. All right. Now, when the estrogen peaks, it goes and stimulates LH. This LH surges, and this LH surge, it causes ovulation. Got it? So, now, once LH surge causes ovulation, here you can see, this is the estrogen. This is where the LH surge is happening. And this is at the same time, ovulation is happening. So once this LH surge occurs, ovulation is triggered. The journey of ovulation begins during the late luteal phase of the previous cycle. All right. So we know that when the previous cycle, late luteal phase happens, there 2 to 5 mm follicles, they are selected. These follicles should be healthy and they are selected from the entire population from which the next menstrual cycle will proceed. Now 2 to 5 mm follicles will be selected and from that only one dominant follicle will form, which will ovulate and which will lead to the process of egg release. So for this, we have divided the phase of folliculometry or the phase of follicle recruitment into three parts. The first one is from day 1 to day 5, which causes follicular selection. Now this starts in the previous cycle itself, but in ultrasound it will be evident from day 1 to day 5. This is called as follicular selection. Now here usually the follicles are 5 to 10 mm in size. Then from day 5 to day 7, it is called as stage of dominance. This is where you will start seeing a dominant follicle. So here you might get follicles near about 10 mm in size. Now the growth rate of a follicle at around this time is 2 to 3 mm per day. Once a follicle crosses 12 mm, it is called as dominant follicle. Now from day 12 to day 16, this is where your LH starts and your LH will surge and this will lead to ovulation. Got it? Now, historically, we had many methods to track ovulation. For example, basal body temperature, the calendar method. Tracker apps is recent, but still not so dependable because we have more irregular cycle patients now. Ovulation strips are too much in use. Fertility awareness months were there and fertility monitors were there, in which they used to have the thermometer and it used to tell. But nowadays, these are all conventional method. But nowadays, we have a very good tool, that is ultrasound, and it gives you precise result of ovulation. Monitor the folliculometry in both stimulated and natural cycles. So now let's start. What is follicular monitoring? So this is a simple technique to assess ovarian follicles on regular intervals. So mind that we have to see them at regular interval. It is not just one stop. It helps in documentation also. So when you do an ultrasound, every time they'll come, you will document. So you will see the progress. Or you will see the non-progression. That is, if at all they need a higher dose of stimulation, if at all they need some other agent for stimulation. Also, it helps to assess the morphology of the follicles. So, in other traditional methods, you cannot assess the morphology of the follicles. We will come to it why morphology is important, and the functional activity of the ovary. That means if at all the ovary is stimulating the follicles or not is also seen in folliculometry. Now, it is useful in women of both natural cycles and stimulated cycles. It is also a very vital component in assisted reproductive technology. So nowadays, because IVF is doing very good, we need precision, and precision can come through ultrasound. So the main component of all this follicular monitoring, the main agenda is to catch the window of opportunity. So for example, if at all a patient is undergoing a natural cycle, once, if at all, she knows the precise date of ovulation, she will definitely have coitus during that period. If at all we are doing an IUI, we should know when to do IUI. If at all we are doing ART, we should know that we have to do the ovum pickup before the follicle ovulates. Got it? So that's why we have to catch this window of opportunity. Usually, during ultrasound, we try to predict 24 to 48 hours before the ovulation time. This is where the gynec or the primary physician has the best chances to give them either ovulation triggering agents, or to maybe start IUI process, or maybe timeline the entire thing, whatever they want to do. If at all we predict this phase, this window, it has been seen that there are maximum chances of conception. All right. So our aim is to predict pre-ovulation and ovulation, because exact time of ovulation we cannot predict. So this window, which has the maximum opportunity, should be predicted. Okay. So now let's start. Why to monitor? So first of all, it gives us a better functional maturity of the follicle. You know how big it is becoming and then it is rupturing, or how small it is there, either it is forming or not. So entire functional maturity you can see through the ultrasound. And it also helps in prediction of ovulation. Now this ovulation, as I just told you, it gives us a timing for HCG administration, IUI, ovum pickup, and if at all there is no ovulation, then for the next cycle, planning for induction, maybe with a stronger agent. Also, this helps the clinician to avoid random HCG. So previously, HCG was given according to their cervical mucus consistency or according to the calendar. But now, random HCG is prevented. And because random HCG is prevented, OHS's complications and its prevalence has been reduced because of folliculometry.